instrumental in developing psycho-oncology services in Leicestershire. And when I initially read about him, I looked like maybe there's an old professor who is going to do the course today. But when I saw such a young man, in so little time, he has achieved so much. He has over 300 publications, and most of the psycho-oncology work is freely available on the websites, and he also maybe would try to upload today's session on the YouTube. So maybe later, if you need to go over it again, or if you want to use it for your teams and your hospital, I hope Alex wouldn't have a problem with that. So without adding anything else, I would request Alex to start that important topic. Let's get physical. Thanks, Alex.
Well, thanks for the kind invite, and could be an exciting session. I appreciate Sunday morning is perhaps better spent elsewhere sometimes, watching sports or having breakfast, but this really is a topic that should appeal to you, because this is about your patients. This is not a theoretical topic, about this stress hormone or this antidepressant might help. This is about your patients and what's happening to them right now, on the wards and in the community. And my job over the next hour to hour and a half is to really just bring you up to date with some of the significant issues in relation to physical health, mental health, comorbidity. And this is meant to be a workshop format. It's a big room for a workshop. I appreciate it's difficult to do a true workshop, but what I'd like you to do is shout out any questions or interrupt me. We can make this as interactive as possible, but that's down to you as much as down to me, okay? And I think halfway through, we'll have a little break anyway, because it's quite a long session. So we'll have a little break halfway for specific questions that might come up. So what I'm going to do is divide this presentation into two half segments. The first half is the importance of physical health in mental health. Why should we attend to it? And the second half is about risk factors and monitoring, and also about what to do. At the end of the day, what are we going to do? If I highlight lots of problem areas, that's actually not very useful unless I start to talk about some solutions. So we must fit in the solutions bit somewhere, even if I skip some segments in the middle. If any of you got Google, go online and have a look for this lady, Lisa Smurl. Lisa Smurl. This is a professor who had a cancer diagnosis, but she went to various healthcare professionals, GPs. In fact, she consulted 3 independent clinicians, and every one, because she had a past psychiatric history, depression actually, said, oh, we don't need to worry about your symptoms. It's nothing. It's probably the depression. You're probably somatizing. And her cancer was missed, and she died of the cancer, with it picked up at a very late stage. And then when people looked at the record, they said, but she was attending with these classic symptoms. Now, is this an isolated case that, one lady's care has unfortunately been missed? We all know it happens in life. Is this an unfortunate case, or is there a trend here? Is there a worrying aspect to how physical care is attended to in psychiatric settings? And we need to think, is there a problem that we need to be addressing? Now, one way to open the discussion is by this concept here from WHO, YLL, which is actually years of life lost. Years of life lost. I'm afraid my pointer is not too good at getting up in the morning. Years of life lost is basically the number of deaths from a condition corrected for the life expectancy. So basically, if you die young of a condition which occurs in early life, that amplifies the years of life lost. Yeah. So the worst case scenario is a condition with high mortality that occurs very young, because you are then kind of robbed of all that potential that you would have. Yeah. So a question for you to get you thinking on a Sunday morning: what do you think the years of life lost are due to cancer on average? So if you have a cancer, what does it? How many years does it rob you of on average because of having that cancer? I'm talking here about pretty much one of the most serious medical conditions. What is your opinion on the number of years of life lost? So who votes for, let's say, 30 plus years, 30 to 40 years with cancer on average? Who votes for 20 to 30 years? That's about half of the audience. Who votes for 10 to 20 years? And that's about a third of the audience. And who votes for 0 to 10 years? And who votes for, I know the answer, but I suspect it's coming up on the next slide, so I'll just wait a second. Okay, very clever. So let's have a look at the answer, shall we? Well, it obviously depends on the cancer. I mean, cancer is a very interesting condition because the oncologists have done a great job at introducing these new treatments, new chemotherapies, and new machines which give very targeted radiotherapy. Basically, they have improved the care of cancer. And if you take prostate cancer, 90% of men now survive 5 years. You know that typical 5-year survival statistic they give in cancer? The statistic for prostate, it's done so well. 90% survive 5 years in prostate. And in fact, across all cancers, 1/3 of patients don't die of their cancer at all. They survive the cancer and succumb to another condition, another late life condition, if you like. So cancers have been doing well in terms of medical intervention. Some of it is actually down to early detection. So that's screening, you know, the mass screening programs, which you know exist in most countries. However, the average time across all cancers is somewhere between 10 and 15 years of life lost, which is, you know, a pretty serious amount of time to be removed from your life because of that cancer, isn't it? But it's not 30 plus years as you might imagine. And the reason it's not 30 plus years is because cancer tends to occur in later life in most of the population. Now, why am I going on about cancer and years of life lost? Well, I want to show you on the next slide the ranking of years of life lost through multiple conditions. I don't know if you can see that from the back, but let's take the classic medical conditions like stroke, cardiovascular disease. Well, they're down this end of the table. They're down this end of the table with about 7 to 10 years of life lost. And that's because, yes, they do have accelerated mortality, modest compared to cancer, but they tend definitely to occur in later life. And at the other end, the extreme end, what if you have a condition like HIV/AIDS, which has a very high mortality rate, but also occurs very young? That's obviously very bad news. And that's second to the top. Okay, second to the top on that list. But I've highlighted two things right in the middle there. And in the middle in green, that's cancer. That's cancer with a mean in this study, US data, called SEER data, if you want to look it up online, SEER. The actual mean years of life lost is 15 years with cancer. But what's right next door to it? Right next door to it in years of life lost is schizophrenia. Statistically, if you're diagnosed with schizophrenia, then you lose 17 years off your lifespan. And that's been shown in multiple studies now in the UK, Europe, and USA. And have a look at this slide from Finland, 350,000 patients divided into healthy controls, and those with schizophrenia, and also those with mood disorder and substance misuse. Well, basically on the left-hand panel, that is the average age of death for the healthy control population. You can see it's been increasing, 1980s, 90s, 2000. In the 2000s, the average age of death 75 in Finland, okay? What if you have schizophrenia in the same decade? Your average age of death was 61. 61. That's where this years of life loss has come from, 14 years. And if you have a substance misuse issue, it's obviously even worse. It's even worse in terms of your years of life lost through mortality. And it's not that bipolar disorder and depression are devoid of an effect. They have an effect too. So what we have here is a demonstration that the years of life lost for mental health conditions is comparable to having a cancer. Yes, the actual mortality per patient is different, but the age of onset overcomes that, and so the overall effect is comparable. Now that's been a wake-up call for psychiatry over the last 10 to 20 years. Because only in the last 10 years have kind of 10 studies come out with the premature mortality, not addressed by the old terms relative risk and risk difference, this kind of thing, which we used to look at, but the actual number of years of life lost. Okay? Now, what's been the trend in different countries? Basically the same trend has occurred in different countries. So this is now Denmark, Sweden and Finland. And just to say, on both of these slides, the years of life lost have slightly improved. Slightly improved. You can see there's a slight catch-up, but not back to normal. Arguably, mood disorder in Finland is the exception. But with schizophrenia, the catch-up, in other words, are we reducing, it's called mortality gap. Are we reducing the mortality gap? It's not really been shown to be reducing. In fact, in Australia, it seems to be getting worse. In the UK, it's not clear. The data isn't brilliant in the UK. So what I'm saying there is the mortality gap still exists and is still a concern. Now, what you should ask me next is, well, what is causing that mortality gap? Because what psychiatrists say, well, oh, well, yeah, of course, because they're dying, aren't they, from suicide? You know, the classic psychiatric red flag, suicide. Is it all down to suicide? Well, if you look at the cause of the mortality in patients who are dying with a mental health condition, this is from US states, divided by type of condition. Suicide is now illustrated here in blue. Suicide is a high relative risk compared to the general population, but the absolute percentage explained by suicide in schizophrenia is between 13 and 15%, depending on the study. And 3 studies merged together show about 13%. So 13% of deaths are related to suicide. So what is happening to the other 85%? Well, it's due to general medical causes. General medical causes that are amplified in schizophrenia and in depression. And what's the most common general medical cause? Well, cardiovascular disease. Cardiovascular disease is the one in red there. Cardiovascular disease related to an enhanced collection of background risk factors, which we might call cardiometabolic risk. And this is now the focus of attention in mental health, to say, yes, we do know about suicide. We're not forgetting about that. We're actually quite good at looking at risk assessments. Whether we're good at doing anything about it, I'm not sure. But now, if I'm saying in terms of mortality, cardiometabolic risk is important, we need to be attending to that a little bit more than we did. Now that's all about mortality. And you'll be saying, okay, that's fine, but what about burden of disease? So burden of disease is how much is somebody held back by their condition day to day? How much are they out of role? How much are they not being able to work because of their condition? And if you look in, you can do this search online actually. There's a massive calculator that is available. I'll give you the link later if you want to look at it. But essentially you can put in your country, and I've just put in Western Europe here. I've put in top 20 causes of burden, and I've put all ages, and I've selected both male and female, and I've said show me the ranking for basically high income countries. So basically the ranking on the left hand side. Number 1, competing with actually back pain, which is a massive problem for primary care. You know, because back pain's hard to clarify the cause, very prevalent, and causes a lot of days out of role. So competing with that on terms of days out of role is depression. In some charts it's 1, in some charts it's 2, but they're basically about the same. So number 1 in the ranking, depression. Number 6 in the ranking, anxiety. Number 10 in the ranking, dementia. Then drug addiction, alcohol problems, schizophrenia, dysthymia, and bipolar. And that's the ranking for all conditions. I've just picked out mental health. Each one that is not mental health is interspersed in there. Okay? So burden of disease is very, very important from a mental health point of view. Now, one way to then bring in the comorbidity question is to focus down on burden specifically in terms of what do we mean by days out of role. So here's a definition of days out of role. Basically, how many days were you unable to perform your usual activities, or did you have to cut down on your normal activities because of your health problems? That would be a typical survey question. So have a think to yourself, in the last year, have there been any days when you personally haven't been able to function, or haven't gone into work, or had to not do something that was very important for you? Have there been any days? Hands up for anyone who would say yes, there have been some days. In fact, that's about 3/4 of the audience. So let me tell you, statistically, the number of people in the population who say I have a whole day out of role, measured by the number of days out of role out of 365, is, well, statistically, the mean number of days out of role is 5 for the general population. If you don't have a major diagnosed disorder, 5 days out of role, which is, modest, although it might be 10 or 15 if you include the item cut down. I had to cut down. I had to hold back. So that encompasses a few more patients. Now, there's a fantastic survey from Australia, basically the Mental Health and Wellbeing Survey 2007, which has produced a lot of data which is available in various papers. And one of the nice things is it's a very large survey, 18 to 65, 8,800 individuals in that study. And this is the data that they found on days out of role. Now, what's interesting from this data here is that in the general population, the number of days out of role was 12 if you didn't have a diagnosis that was coming to medical attention. If you had depression, the number of days out of role was 50. 50 days out of role in that typical year. If you had anxiety, 25, 26. If you had a physical health condition, any, 30, okay? And what happens if you have depression, anxiety, and a physical health condition together? 109 days out of role. And that's the mean for anyone who reports those 3 things together. So what am I saying there? Approximately a third of the year out of role on average if you have a physical health comorbidity and a significant mental health issue. A third of the year out of role. That is a major burden. And in fact, looked on another way, depression on its own accounts for 5% of everyone who's out of role on any given day. So everyone that's off work, depression is the #1 explanation. And it accounts for 5% of all people out of role. And that's been shown in various surveys, but the proof is in this one, 63,000 surveyed in the World Mental Health Survey. And this is called, in yellow here, attributable risk, which is how much of the days out of role is caused by that condition. And 5.1% is due on its own, just on its own, to depression. So that's a very, very major concern. That's days out of role. Now let's move on to this question of disparities or inequalities. What do I mean by an inequality? What I basically mean by an inequality is a difference or disparity in healthcare by virtue of the person's demographic status, their ethnicity, their physical health condition, or their psychological health condition, which should otherwise be delivered equally if that condition wasn't present or that characteristic wasn't present. Okay? So what I'm saying is a difference by virtue of X, which if X wasn't there, they should really be receiving equal treatment. There isn't a good reason to not give them treatment other than they're from an ethnic minority group or they're an older person. You see what I mean? If we said that I'm not going to give you a coronary artery bypass graft because you're over 65, generally the NHS is saying that's not a good thing these days. Unless by virtue of them being over 65 there's a specific contraindication. You shouldn't be saying just because you're over 65 you can't get the treatment. Does that make sense? So that's what I mean by a disparity or inequality. So what if I told you then that rates of treatment receipt are different depending on mental health status? What do I mean by that? Well, take cancer. I mentioned cancer earlier. In cancer, what are the chances that if you're diagnosed with cancer, your cancer will be treated if you are living in a high-income country? Well, the answer statistically is 98%. If you have a cancer diagnosed, 98% of people will receive treatment for that condition. 2% for a variety of reasons, and that's a very interesting 2%. But 2% will not receive treatment for their cancer. Maybe they refuse it. Or maybe they're not offered. There's various explanations there. But 98% receive treatment for their cancer. What percentage of people in a high-income country receive treatment for their depression in a reasonable period of time? It's a question for the audience.
50%.
Is it 50% or higher? Hands up for 50% or higher. That could include 51%. Is it 30 to 50%? I'm talking about in a 12-month period, a reasonable time. Obviously, if you said, well, I'm following patients over 20 years, did they ever receive? That's not very helpful, because being delayed 20 years is not very good. But 12 months, yes, that's a reasonable period. So that was a third to a half. So the rest of you are then saying less than a third. How many less than a third? No one. Okay, so here's the data on receipt of depression from the best study in the literature, which is from Philip Wang, a very impressive international researcher of psychiatric epidemiology from the States, Harvard, I think. And that's published in Lancet, 2007, if you want to look it up. So what does this show? Well, this was part of a multi-center face-to-face survey, 84,000 patients surveyed. And this is one piece of data. The percentage of people receiving treatment for depression where they were diagnosed as depressed, and within a reasonable length of time, I think 12 months was the time period given. Now it depends on the country. Here we've got high-income countries and low-income countries. And the most likely country, if you were depressed, for you to be receive treatment, if you were living in that country, is the USA, where you can see the rate of treatment receipt is about 18%. Okay? So that's the maximum, 18% in the USA. And the minimum was actually Nigeria. If you're living in Nigeria and you were depressed and recognized as depressed, the chance of you receiving treatment was unfortunately 2% in a given year. So that's low. Now, does that then mean that in a medical setting, if you were, that's probably mostly in primary care. 80% of depressions are treated, if not more, in primary care. So what would the situation be in a hospital setting, or in a medical setting, or in a psychiatric setting? Well, let's take a hospital setting. So let's take somebody with a comorbidity, somebody with cancer, who then is depressed as well. Now, in the UK, the rates of receipt of depression treatment in a year hovering about 30% roughly. So that's what I've written here. If you have depression, your rate of receipt is 30%. And a study from Hewitt was published in JCO, which is the Journal of Clinical Oncology, compared receipt of depression treatment if you had cancer or if you didn't. Basically, if you had a comorbidity or not. Now, the implication here, let me just run this by you, is this. If you have cancer and depression, you're presumably getting treatment for your cancer. You're coming to a center. You're in specialist care. So surely your secondary condition, your depression, would be more picked up. You've got cancer nurses there. You've got oncologists. You may even have psychiatrists. You've got liaison psychiatrists like Taib, very regularly on the wards. And the answer is it doesn't make any difference. Statistically, it was 30% whether you had the comorbidity or not. The receipt, the acknowledgement of cancer, the presence of a big medical hospital did not influence your receipt of psychiatric treatment for the depression. It was the same low rate, 1/3. Now, I've heard people say, okay, so yes, it's low, yeah. Well, it's hard to detect depression, If it was a symptom, like low mood, it would be a lot easier. They just have to look for low mood. Well, is that true? Well, you can make a comparison against the symptom of something else. If you said the comparison against cancer is not very fair, because it's a barn door condition, everybody comes to attention, and it's such a clear condition. Make a comparison against pain then. Pain. Now you see, pain is basically a symptom, and it's often got a diffuse origin. Usually GPs, even hospital specialists, are hard pressed to find the root, the cause of that pain. So if somebody presents with pain, I would argue that's pretty much a level playing field for presenting with low mood, which might be a major depression, yeah? So what would the rates of receipt of pain treatment be? Well, the answer was shown by a colleague of mine in Florida who looked across 1,600 patients in Florida cancer centers. Now, Florida is a massive state, and so these are all individual cancer centers in Florida. And basically what he did with a team of researchers, he went to look at the medical notes and then asked the clinicians, did you recognize X? Did you recognize Y? And did you do anything about it? Well, in this slide I've got here, did you recognize the emotional problems? A proxy for depression. And did you recognize pain? And pain is in purple and depression is in beige. And what you see if you average them all is that pain was recognized and treated in 80% of instances where the patient had pain. But depression in Florida cancer centers was recognized across the board in 50%. There was a definite disparity between pain and depression. And yes, I will admit, in some centers, like Center A, they were actually doing well. Whatever they were doing in Center A, they were picking up 85% of pain and depression. They were doing a good job in both. And some centers, sadly, like Center H, were not doing well in either domain. They were pretty much missing both. So that's not good either. In other words, this is not all totally fixed and invariable. There are institutional factors and individual clinician factors which are influencing whether patients receive equal and fair treatment. And I've summarized what I've just said there on that slide. Now, this is also reflected in national guidelines, and I won't go through this in detail, but basically some studies have looked at what percentage of patients who have a variety of conditions receive equitable, they call it guideline concordant care. Guideline concordant care basically means it adheres to the standard of the day in that condition. So your best case scenario in medicine is that you have a condition which is very simply treated or very effectively treated, that there's basically one clear-cut treatment for that condition. And that condition is recognized by society but not feared by society, so your presentation is good. And the treatment itself is reasonably cost effective so that it's supported by various health organizations such as the NHS. So a barn door condition, which fulfills most of those categories, would be an example, cataract. Cataract is usually pretty straightforwardly treated. And that's why if you look at adherence to standards, the adherence to standards in cataract is 80%. But if you look at depression, the adherence to standard is fallen to 60%. If you have an alcohol problem, your adherence to standard, that is basically how likely are your clinicians to do what they're meant to do for you, it's down to 10.5%. Now think of alcohol problems. They merge with society in general. At-risk drinking is said to be present in 10 to 20% of the population. Is it acceptable or unacceptable to drink? Society doesn't really know. Is it a medical condition? Well, in some situations, yes, but mainly by virtue of the complications. Is there a clear treatment available? Well, yes, particularly for abstinence. But relapse prevention rates are pretty bad. The relapse prevention rates are poor in all the addictions. So the long-term treatments are not good. And whose responsibility is it for alcohol problems? It's a variety of people. Is it liver specialists? Is it GPs? Is it AA, the voluntary sector? Is it us? It's a variety. The responsibility can be lost with some conditions. And that is why, guideline concordant care can be very low with some conditions. Now, another angle to this is this. If you have a mental health condition like depression or schizophrenia, I've already said your adherence to your own standard of treatment for that condition is low. But could the depression or schizophrenia adversely affect receipt of care for your medical condition? Go back to slide 2, which was Lisa Smurl, who didn't receive care because she was thought to be depressed. She was written off because she was thought to be depressed. Is that an isolated case, or is there a problem? Well, I said to you that receipt of cancer treatment, if you have cancer, is 98%, yeah? Here's the slide showing that. If you don't have a mental condition, and you're seen in a high-income country, this is actually from Belajon, and I think this is French data. So the receipt of cancer treatment, if you're known to have cancer, is X minus the percentage who are not treated, which is 2%. And what are these bars here showing? In the same study, if you had depression, your chance of not being treated for your cancer was 3 times higher in terms of relative risk. In absolute numbers, most are still treated. Obviously, if you've got a depressed cancer patient, most are still treated. But what I'm saying is there's still an inequality. A psychotic disorder is 6 times more likely to not receive treatment. That is a serious concern. So, and dementia. Now, whenever I say, I present this to my medical colleagues. They said, oh yes, dementia. Okay, well they don't need treatment, do they? Well, 80% of dementias are very mild. Yeah, 80% are mild, 15% roughly moderate, and 5% severe. Yeah, so it's not necessarily appropriate to say everyone with a cognitive disorder, everyone with a psychotic disorder, everyone with a depression should not access care. That's not right. There's something going wrong here. Okay, that's a red flag. That's a red flag saying there could be a problem. But are there other areas where there could be confirmation that there's an inequality by virtue of their mental health condition? And I just want to highlight 3 areas for you. And that is mass screening, surgical procedures, and medical treatment. So in mass screening, for example, cancer screening, or screening for a variety of medical conditions, then we've done a meta-analysis on this. It came out in British Journal of Psychiatry. And that showed that if you have any of those conditions, your receipt of mass screening was less than the general population. And if you had a psychosis, the odds ratio was 0.5. You were 0.5 as likely in terms of odds to receive mass screening if you had schizophrenia. Okay, that's a second red flag. What about procedural treatments? If you have myocardial infarction and you have schizophrenia, you're half as likely, 0.353 hazard ratio, that means exactly half as likely in percentage terms, to receive coronary artery bypass because you have schizophrenia. So 2 equal patients, one with schizophrenia, one without, one generally healthy but both having a myocardial infarction. The one with schizophrenia is half as likely to receive coronary artery bypass graft. Why? Why is that? Just have a think about that. Why is that? And if you have any mental ill health, you're 10% less likely in general to receive coronary artery bypass graft. It does go across mental health conditions. It's not just schizophrenia. And what about receipt of medical treatment like aspirin or antihypertensive ACE inhibitors? Yes, the same thing applies. There's roughly a 10% differential on the receipt of medical treatment by virtue of you having a mental health condition. Why? What is going on there? So these are prescriptions from medical doctors for a medical condition. And what the database has done is found out whether or not they've got a mental health condition. And those with a mental health condition, on average, are 10% less likely to receive the treatment. Now, some people say, I know the answer straight away. They're refusing. They're not turning up. The patients with the mental health condition are refusing or not turning up. Strangely, the literature doesn't really support that in terms of medical care. Those with a comorbidity are often attending more. Now, they're not always attending with their medical condition, but in terms of numerical contacts, they're often attending more. But let's come back to that in the discussion, if you like. And now, is this all innocent? Is it all innocent? Meaning that are all these disparities of theoretical interest? Yeah, there's a disparity, 10%, 20%, 50%. Does it matter? Well, after a myocardial infarction, patients with depression have an 11% higher mortality rate. But they have a 10% inferior receipt of medical care. Is that a coincidence? They're roughly at the same ballpark. A 10% increased mortality and a 10% inferior care. I don't think that's a coincidence, but how do you prove it? How do you prove it? And that's the problem for a study. This is where we're at right now. There's a signal here which is worrying. But how do we prove a link? It's very tricky to prove that link, that it's definitely due to receipt of medical care. Any questions so far on what I've covered?
Alex, can I take you back for the depression, the figures you told that 80% do not get? This is a bit of it doesn't fit in common sense.
Yeah.
Is that we're talking about unhappiness or just a low mood, or other? 80% not getting depression treatment is quite a big number. I wonder whether you could expand on it.
The reason that it's 80% and your personal experience is less than that is because you're personally seeing people who've gone already through several filters. They have thought, I've got a problem as the patient. They have then taken the jump, the leap of faith to come and see a clinician, usually their GP. Yeah, the GP has taken, in the case that we're talking about, your patients, a careful examination, reasonably careful, about what's going on. And then they've written you a very brief referral, very brief, usually, for the patient. And then the patient's turned up to see you. Yeah? Then you've seen the patient and you've said, oh, you're depressed. Let me have a look. Are you on any treatment? And they've said, yes, I'm on a SSRI. Yeah? So that's your typical psychiatric perspective. But they've gone through all those filters. Now, every one of those filters, which were elucidated by David Goldberg in the 1980s, were shown to be barriers to care. So, for example, a certain percentage of patients don't seek attention in a timely manner when they have a significant mental health condition. I can put a number on that. How long do you think it takes the average person to seek attention if they have depressive symptoms? Now, you know about the concept of DUP, duration of untreated psychosis. It's very popular these days, isn't it? Well, what about DUD, duration of untreated depression? Okay, I can tell you now it's longer than the DUP, which is 2 years. So what's the DUD, which is duration of untreated depression? 6 years.
Alex, my first issue will be, what depression we're talking about. Because,
okay.
There's a core syndrome, which in the old language,
yes.
When my generation started training, we used to call endogenous depression.
Yes. Well, so did I.
With the biological markers and all that, that concept we know for thousands of years.
Yes.
And then there are other social constructs,
yes.
which are of more recent origin,
yes.
which have been complicated by the heavy selling of ads and whatever other, social concordats we get into.
Yes. Well, I do.
Everybody's depressed.
I do agree with you.
And the Kirsch's, meta-analysis, which created a lot of ripples.
Yes.
And my reading of that data is that it actually validated what my age was being taught and trained in 1980s.
Yes.
That you find a core syndrome.
Yeah.
You can predict how it will respond to treatment. And then there are other depressions, whatever you call them in ICD-10 or DSM-4 language or DSM-5 language.
Yes, yes.
And it is anybody's guess whether the intervention will be any better than placebo.
Yeah. Well, I'll tell you, there's some truth, a lot of truth in what you're saying, but there's also a slight misunderstanding. Now that is because you're talking quite robustly from a psychiatrist's point of view. And we will all do that as psychiatrists because we see the most severe cases, the one where treatment is most warranted, the ones where you couldn't argue that a clinical depression is there. But what we don't see, well, you could argue, now we may be seeing more, but we don't really concentrate on the mild cases, the cases that are not coming to our attention, the cases that are treated in IAPT and primary care, and in fact the cases that are not even coming to primary care. Now those cases are not actually categorically different from the core clinical disorders that we see. It's just we are cutting them with Occam's razor, as it were, and seeing the severe end. However, we know from very large surveys, and one is the Hampshire Depression Project in Southampton, which rated, I think it was 18,000 depressed patients with the HATs, and other instruments have been done as well. And basically, if you take the trouble, which none of us could ever do clinically, to rate these patients, you find that depression is on a complete continuum. It's on a complete continuum. Now there's a skew towards actually minor symptoms. So mild depression is obviously more common, 70 to 80% mild, roughly 10 to 15% moderate, and 5 to 10% severe as a ballpark figure. Now of course we're seeing the severe ones, which warrant medical attention. But the question is, where does the burden of depression lie? Does it lie with the 5% who are severe, or does it lie across the spectrum? Now this is a very interesting epidemiological observation, and it's the same for observation that's been found in suicide risk prediction. That if you then do a risk assessment tool which looks for the most risky cases, you think it's working quite well, because it's picking up these people with a lot of risk markers for repetition of self-harm and suicide. But in fact, a lot of the burden of suicide is in those with actually quite minor or subtle risk factors. Some people present on their first occasion with a suicide attempt with no past psychiatric history at all and no clear risk factors. And actually, if you look at the burden of suicide, the majority comes from those people who are not rated as severe in a risk assessment tool. Now the reason for telling you that is the same in depression. Most of the burden in society, which could be measured by things like days out of role, actually comes from mild depressions and moderate. It's not because they have more days out of role than the moderate and severe. They have much less, but there's so many more of them. It's an epidemiological observation. And this is why it's dangerous to forget about the mild and moderate cases. It's the same in dementia as well, dementia care, and the same in alcoholism as well. You know, it's dangerous to forget about the mild and moderate cases. Now, the hospital settings encourage us to concentrate on the most severe, those that will stay longest and arguably have most response to treatment. And I can see why they do that. But a lot of the burden in society is living out there in society as a whole. Now, this is where your question comes in as well. Because you said, how come it's 80% untreated? The reason is, in that Philip Wang study, they were household surveys knocking on the door in the community, not knocking on the door of psychiatrists or even in primary care. So most of those people who were symptomatic were not necessarily getting a diagnosis. And a lot of those people who are symptomatic may not even have recognized that they had symptoms. And I put that question to you a few seconds ago. What is the average DUD? Well, it's been shown to be 8 years. It's 8 years from somebody to have a first significant symptom of depression to coming to medical attention. That's statistically the mean time when more than 50%, actually 50% or more, come to medical attention. 8 years.
Depression is episodic illness. A number of the depressions actually make spontaneous recovery. So you will not expect a mild to moderate depression to last for 8 years. Another thing is, when you are doing door-to-door things, you might be catching that person who might be depressed and the next day is fine. So I think if you want to label that person as depressed, you might have to do extended observation, not just on a day.
You're quite right. So the gold standard here is not a single observation, because in that pool, some of the people who are depressed are recovering. Arguably, that is the placebo group in Kirsch, but it's actually not the placebo group. It's less than that. And the reason is, when Kirsch looked at placebo studies, he's actually looking at the offer, everything except the antidepressant. So the offer of help was there. The offer of support, the follow-up was there. That is all very powerful. All that human stuff is very powerful, as you know. Now, where you are correct, however, is about the false positives being a problem and the fact that antidepressants tend to be overprescribed. How many antidepressants are prescribed each year in the US? 250 million prescriptions. How many in the UK? 50 million prescriptions a year. What does that mean? There's basically one prescription per year for every adult in the population. I'm not saying that every adult receives a prescription, because on average, people receive 5 prescriptions over the year. What that then means is 1 in 5 of the population in the UK and US are on an antidepressant at any one time. 1 in 5. And probably most of those are not clinically depressed.
Exactly.
So
the confounders like pain relief, amitriptyline being prescribed for.
That's a small number, but it's actually all those tail that you were talking about with symptoms of depression but not qualifying.
Yes.
It's not that they often have no burden at all, but they have a mild depression or subclinical depression, or they have a competing diagnosis which you wouldn't necessarily think, oh, I need to prescribe an antidepressant. For example, work-related stress or bereavement. There's obviously any possibility is in there. It's a mixed bag. But false positives are a major problem. And that is partly related to your point that in medicine, when your GP assesses depression, generally they do so on a one-off appointment. Patient comes in, they say, I've got a problem. At work, I'm stressed. And the GP says, how are you sleeping? That's the number one question for depression, by the way, in primary care. And they generally make their mind up within that 12-minute appointment quite quickly and decide, am I going to prescribe an antidepressant or, if available, prescribe psychological treatment if it's available in the local practice. Yeah.
So actually prescribe medication even without seeing a patient. Either the wife will go and say to my husband is like, I am a child psychiatrist.
Yeah.
And actually, in number of cases, mothers will go to the GP. Oh, my adolescent is depressed, he is not sleeping well.
Yeah.
And GP will issue a prescription of antidepressant.
Yes.
And he might not, sleep problem might be they're sitting on the internet, not that they have true sleep difficulty.
I do take your
so
point.
I think all the prescription issued by GPs are not, might not be depression.
Well, they should only issue a prescription for those that they've seen. But I take your point that the assessment may be inadequate. And I take your previous point that a multiple assessment is more accurate than a one-off. In fact, we have the statistics on that. If we published this in Lancet in 2009, if a GP does a one-off assessment for depression, how accurate are they at identifying depression? One-off appointment, the patient's depressed, clinically depressed, according to the official guidelines. Okay, they are, and we're checking on it by an exit interview with the patient at the time. So how accurate are the GPs?
50%, I guess.
It's correct. It's 50%. Now, it's actually only 50% if you say to the GP, I'm going to see if you're going to correctly identify depression. In other words, it's only 50% in the context of a study where you're scrutinizing them. If you don't scrutinize them and you just look in the notes, it's 30%. 30% is the detection sensitivity based on routine care. 70% are missed. Now that's based on one-off. But what we found is that if they did 2 or more appointments, their accuracy goes from 50 to 80. But they don't often do that. That's like almost now your old-fashioned GP who's prepared to take you on. Now the reason they may not do that is because in a multiple shared practice, you may see a second GP who doesn't know you, apart from there's some note in the notes. So is that really a second assessment, or is it 2 independent assessments? You see the problem?
You spoke about the psychosis and how schizophrenia can, each patient with schizophrenia, the lifespan is shortened. Have there been clear studies about treated and untreated schizophrenia? And is there a difference in their life expectancy? The point is it the drugs which is making them more likely to have metabolic syndrome and die? Or is it the inherent property of schizophrenia itself that they died earlier?
Well, let me put this to the audience, because I can unpick this for you. Untreated schizophrenia is a rare entity in westernized medicine, especially in a research study. Because if I come along to your practice and say, I'm interested in studying schizophrenia, I want to look at cardiometabolic risk, you say, yeah, get the ethical approval, we got it, start the study next week. And I say, okay, now I want your untreated patients. You're going to say, well, I don't keep them all untreated for you. That's ridiculous. Maybe if you recruit serially, I can give you a patient who I'm about to start treatment tomorrow, but I can't withhold the treatment. So it's a rare entity. So.
But Alex, it contradicts, when you say duration of untreated psychosis.
In the community.
In the community, exactly.
Yes.
So, yes, they will not be sitting on our caseloads.
No.
But anecdotally, I can tell you, I'm not a research scientist, but anecdotally I know that in my community patch, every time a referral says, young man, mid to late 20s, depressed for 2 years, not responding to antidepressants,
yes,
my heart sinks.
Yes.
That it's undiagnosed schizophrenia.
Yes, that's a fair point. And we know pretty much all mental health diagnoses are missed with a significant proportion. And our own team, the research team, we've published in dementia recognition, which is for non-severe dementias is the equivalent miss rate for depression. Basically 1/3 of mild dementias are detected by the GP in a timely fashion. Okay, alcohol problems, the same ballpark figure. In fact, alcohol problems, we were able to compare GPs, hospital doctors, and psychiatrists. Do you want me to tell you the bad news? Assuming you don't know the patient has an alcohol problem. Obviously, if you do, that's a nonsense. There's no study there. I'm talking about random patients who may or may not have an alcohol problem. Okay, first the good news. Psychiatrists were the best. Now the bad news. They're only 10% better than GPs. GPs were detecting about 45% of alcohol problems, but psychiatrists detected only 55%. And the hospital specialists detected 40. They were low. But it was all compressed. So don't think we're all off the hook here. If I don't tell you patient X has got this condition, you may struggle to detect it as much as anybody else. But if you've got only 10 conditions to look out for, you'll have a slight home court advantage, because your screener or your questions would necessarily only have to be focused on there. But I'm coming back to your point about the first episode psychosis and the untreated patient. So let's say I systematically now study my patients with schizophrenia and severe mental ill health, ideally those on and off antipsychotics. And then I look at the literature and see who else has done that. Well, that's exactly what we've done. We've done a big study. It's just come out in Schizophrenia Bulletin last year. And what we found is there's 300 studies of metabolic syndrome or metabolic risk in relation to patients with schizophrenia prescribed antipsychotics. There's 300 studies. But there's only about 20 studies of patients who are either first episode or drug naive. It's a rarefied group. So I want to tell you up front, I do have a caveat that we haven't got like mountains of data for untreated patients. We have a little bit of data, and that gives me enough to stand here and tell you the answer. But I would like more data on this as well. But I can tell you the data on the established patients with chronic schizophrenia maintained on antipsychotics, there we have mountains of data. And I can tell you their metabolic risk in each domain. Lipids, blood pressure, weight, glucose, fasting glucose, HbA1c. I can tell you all of those. Smoking status. I can tell you all of those. So my question for you, before I show you the answer to this chap's very good question, is what do you think I'd find if I studied drug-naive first episode patients who do have schizophrenia for their cardiometabolic risk? Am I going to find, basically, to put it in a nutshell, that the cardiometabolic risk is already getting bad. It's already a concern. And basically, the disease itself is what we're talking about here, because they haven't been treated yet, so it can't be the drug. They have never had a drug in this case. Or is it the case that cardiometabolic risk in patients who are drug naive but have schizophrenia is actually comparable to the general population of an age-matched patient? Or is it some other possibility that you're going to tell me? So who votes for option one? It's already a concern. It's a signal. And we need to think about this seriously in terms of schizophrenia being a major worry. So that's about nearly half. Who's option two, which is it's basically at the control rates when you're in a drug-naive state. So that's only about 5% of the audience. And any other suggestions? Is there any other possibility? Have I missed out some hypothetical possibility that's not explained? Any other suggestions for that?
Well, the inherent risk, which is multiplied by the treatment.
Yes, so you're saying both apply.
And lifestyle changes.
How would the lifestyle changes be manifest? Tell me how that would work.
To try to put it simply, the way the personality changes in schizophrenia, in the sense of person withdrawing from activities and, typically a young person, not getting in an active lifestyle, to put it simply.
Yeah.
They're more, at risk of putting on weight and all the risks which go with that.
Yeah. Okay. I'm glad you said smoking. Because I'm going to show you the answer.
If you don't go giddy.
Right.
And the way you're flipping the slides.
I think you just wanted me to cut to the last slide. So you could have a break early and have coffee, which is not provided, I hasten to add. Right, so so here's now, okay, so what I'm going to show you now is all the data crunched together, chronic schizophrenia, first episode, and drug naive. So the really gold one is the drug naive first episode. The drug naive is also first episode. First episode can be treated or untreated, but if they're untreated, they're drug naive and first episode, okay? And then I'm going to show you the metabolic components, and I'm going to show you the relative risk compared to the general population. So here's the answer. Basically, if you look at the general population is in grey. In the dark is your patient with chronic schizophrenia. And you'll see, in metabolic syndrome, that is 3 of 5 major risk factors called metabolic syndrome. Waist or weight, blood pressure, lipids, triglycerides, fasting glucose, which is basically pre-diabetes, HDL lipid, and smoking and diabetes status, okay? In the dark, the patients with chronic schizophrenia are bad on every domain. Metabolic syndrome as a whole is severe. It's 30% compared to 10% in an age-matched patient. It's severe. What about diabetes? Diabetes in patients with chronic schizophrenia on antipsychotics is 12% prevalence. That's across all studies, although we found in our very thorough study of diabetes, which I'll show you after the break, that the rate is actually higher, and pre-diabetes together very, very high. However, from the literature, 12% for diabetes, but the population rate for diabetes is 4%, and the age-matched equivalent would be 2 to 3%. So we're talking about six times relative risk of diabetes in those with chronic schizophrenia on antipsychotics. However, some of you are already looking ahead to the yellows, and the light yellow is those with unmedicated first episode. And you'll notice that light yellow is actually low on nearly everything. It's low on nearly everything except one thing, which is this one, which is smoking. So what that tells you is, and I put my caveat about low numbers for this meta-analysis. We could collect more data in the future, but this is where we're at right now, 2013. Metabolic syndrome and all metabolic risk factors, including pre-diabetes, is not substantially elevated in first episode patients who are not medicated. However, their lifestyle risk factors are there. And the classic one is smoking. But diet, exercise, and impacting upon weight, if you want to put that in that category, are all affected as well. Not so much weight, but more a diet, exercise, and smoking, and obviously alcohol as well. So smoking is already a signal at day one. In fact, if studies that have looked at pre-schizophrenia, smoking rates are higher than the general age-matched population. And smoking rates in the general population since 2010 in the UK and US have come under 1 in 5 for the first time. Only 20% of the general population are smokers. In fact, more of the population are ex-smokers than smokers now because of the trend to give up. But in schizophrenia, the rate who are smokers in the meta-analysis is 55%. And in the Australian second wave of psychosis, which came out 2013, very current data, Galletri is the first author. The rate of smoking in males with schizophrenia, 70 to 75% current smokers. Very, very concerning rate of smoking. Now, what does that tell me then about your answer? Basically, nearly everyone thinks what you thought, the majority answer, that risk is elevated in the unmedicated, but it's really not. And it's because people haven't seen this very new data from the last 5 years. You're making an assumption based on chronic schizophrenia that the risk is high. Now, risk is high based on lifestyle, but it's not yet manifest biochemically, except in 1 or 2 outlier studies, such as the study from Ireland by Jogin Thakore, who showed that on advanced measures, for example, insulin, that patients who with schizophrenia did have a slightly abnormal glucose regulation at baseline. But that's the exceptional study. Most show that the metabolic profile is essentially normal in that stage, but it quickly becomes abnormal. I'll give you that. It quickly becomes abnormal, and that is a major concern. And you are right that lifestyle factors come into play. But that tells me then that perhaps the most guilty party is you and me and every one of us by prescribing antipsychotics and other drugs that are not helping the patient's metabolic risk. And often we prescribe them, but patients continue on them for a long period of time, as you know, particularly in modern psychiatry, where shared care agreements have come in, meaning that we initiate, but more and more drugs are being given to primary care colleagues to follow up. But they don't necessarily have the expertise or confidence to stop them. So patients often stay on their drugs for a long period of time. And I'm not saying it's unethical to prescribe olanzapine for schizophrenia. It works very well. What I'm saying is it may be seen as unethical very soon to continue the patient on it without anything else offsetting their metabolic risk. And what might offset their metabolic risk we'll talk about in part 2 of this talk. Yes, if you look at cardiometabolic risk, it depends what you look at, but pretty much this boils down to this, that although you've got a session on ECG, and I've written a paper myself on cardiovascular ECG problems in relation to antipsychotics, most patients don't die of an arrhythmia. Most patients die of mainstream cardiovascular, atherosclerotic, ischemic heart disease, stroke, and your mainstream medical causes, which actually often relate to weight and glucose regulation, along with hypertension and smoking. Those 3 things. Okay? Now, is there a difference? Yes, there is a difference. And in terms of weight, there's a ranking, which I can show you later. But clozapine and olanzapine are basically number 1 and 2. And the typicals are not devoid of problems at all. In fact, haloperidol typically increases patients' weight over the first 1 to 2 years by about 5 kgs, whereas olanzapine increases by 10 to 15, which is 2 stone, as opposed to 1 stone. So it's not that the typicals were completely free, but it was a modest effect. It was a modest effect. And because the typicals had a lot of other side effects, like tardive dyskinesia, extrapyramidal side effects, we were cautious about patients staying on typicals for a long time anyway. In fact, because of TD, we wanted the patients to come off as soon as possible. But with olanzapine, that risk is basically squashed. You know, the extrapyramidal risk is basically minimal. So we had this basically naive period from 2000 to 2010, where we prescribed new atypicals a lot because they seemed to be working really well and they weren't causing major problems as far as we know. But what we didn't know, in all honesty, is that the major problems were accruing in the background. And in addition, the major problems were things that we as psychiatrists weren't really skilled to do much about. Like if you see your patient gaining weight, you know they're not eating well. You know they're not exercising well. You know the wards are not encouraging much activities nowadays, generally. So you would have thought, well, yeah, of course they're gaining weight. I mean, I wish they weren't, but it's not like my job to correct it. And that was a naive period. And we're coming to the end of the naive period now, where we can say, well, we didn't know about the problem and we didn't know how to fix it. What we're coming down to now is we now know about the problem. Now the question is, for part 2, do we know how to fix it? And I'll answer your sub-question about, are there differences in relation to weight or diabetes in the part 2? Let's have a break then, yeah? I'll see you in five minutes.